Guys,
screen share frame.
Natty Light, we're recording, so don't say anything crazy, okay?
Yeah.
You're the closest one to it.
Perhaps it's better if you just don't talk, Natalie.
For a change. Okay, I think you're good.
Okay, yeah. All right.
Tell more people.
Or we could just start now.
Whatever you want. Okay. All right. So I think we have enough people here for Parathyroid Palooza. Who's excited to learn for the ABSITE? Just kidding. This is the only super exciting part of this PowerPoint. A lot of it is going to be similar to Gabs's PowerPoint, at least in terms of the structure, and you're going to see a lot of the same anatomy pictures. None of my parathyroids dance though, so it's already less exciting. So we're going to go over the anatomy and embryology of the parathyroids, normal physiology, hyperparathyroidism, which is very important for the ABSITE, parathyroid cancer, which is something that you'll see on the ABSITE, but not necessarily in real life quite as much. And then some of the very basic overviews of parathyroidectomy, and then we'll go through some questions. All right. So the parathyroid embryology is very important for understanding the anatomy. I know it's on the screen, but who can tell me where embryologically the superior glands come from and the inferior glands? Caitlin, you look like you know. Yes, so the superior parathyroids come from the fourth pharyngeal pouch and the inferior come from the third pharyngeal pouch, which is important clinically because the third pharyngeal pouch is obviously higher than the fourth, so the inferior glands travel further, which means they are more often ectopic than the superior parathyroid glands. If you can see on the screen here, where's my mouse? There it is. The superior glands are also lateral and posterior to the recurrent laryngeal nerve, and the inferior glands are medial and anterior to the recurrent laryngeal nerve. So similar to thyroidectomy, the laryngeal, both recurrent and superior laryngeal nerves are often injured in a parathyroidectomy, and the relationship of the superior versus inferior glands is important for finding the parathyroid glands and making sure that you're protecting the recurrent laryngeal nerve. Who can tell me the blood supply that's up there for the parathyroid glands? Yes. In 80% of cases, the blood supply for all four of the glands comes from the inferior thyroid artery. So ectopic parathyroid glands are also very commonly tested. About 16% of people with primary hyperparathyroidism will have an ectopic gland. The inferior glands are more likely to be ectopic, like we said, because they have to travel further, and they are most commonly found in the thymus, which is also associated with the third pharyngeal pouch. Some other common locations are the retroesophageal space, the carotid sheath, and intrathyroidal, which is more common for the inferior. So important on the test, if you get a question that says you have a missed parathyroid gland, what is the most common location? Yes, in its normal anatomic position. If the test asks you, where is the most common location for an ectopic parathyroid gland? In the thymus, correct. Yeah, it's the superior is the retroesophageal. So again, to reiterate for the people on Zoom, The most common ectopic location in general is the thymus because the inferior glands are more commonly ectopic, but the most common ectopic location for the superior glands will be in the retroesophageal space. And then after that, it's the carotid sheath. But if it asks you for a missed gland, that's implying that you just couldn't find it and it's in its normal anatomic position. Okay, so the physiology of the parathyroid glands is we're going to keep it very simple and very easy to remember for ABSITE. So the chief cells synthesize and secrete PTH, and these are the primary cells in the parathyroid glands. They have calcium sensing receptors on the surface of the chief cells. So when calcium levels are low, PTH is synthesized and secreted. So calcium binds to the calcium sensing receptor, and that inhibits the secretion of PTH. If anyone is following along in their BTK ABSITE book right now, you probably got to the part that says PTH is phosphate trashing hormone. So when PTH is secreted, it increases calcium levels and decreases phosphate levels. The mechanisms of action, it acts directly on bone and the kidneys and indirectly in the GI tract. So in bone, it stimulates the osteoclast cells to resorb calcium. So if you remember from med school, clasts chew and blasts build. So the osteoclast will take calcium out of the bone. In the kidneys, it stimulates the resorption of calcium and it inhibits the resorption of phosphate. So you'll have low phosphate, high calcium with PTH. In the GI tract, like I said, there's no direct effect, but PTH stimulates the conversion of the 25 vitamin D to the active form. So that will stimulate reabsorption of both in the GI tract, but the inhibition of resorption in the kidneys overrides that. So you'll have hypophosphatemia with increased PTH. Calcitonin is also secreted by the parathyroid glands, and calcitonin tones down calcium. So this is released in response to high calcium levels, and it indirectly inhibits the osteoclasts. So this is all of that in a chart form because I think it makes more sense to look at it kind of like this. So you'll see up here, when you have low calcium and high phosphate, that stimulates the parathyroid glands to secrete PTH, and then you'll see it acts in the kidneys and bone directly. And then here it just shows the vitamin D activation acting indirectly on the small intestine. So there are three main types of hyperparathyroidism. For we read up there, who can kind of explain the difference between primary and secondary hyperparathyroidism? Pranav. Mm-hmm. Mm-hmm. Yeah, so primary hyperparathyroidism, the issue is with the glands themselves. They are functioning abnormally and they'll secrete excess PTH. In 80% of cases, this is due to an adenoma, usually a single gland adenoma, but you can have multiglandular adenoma. In 10 to 15% of cases, this is due to parathyroid hyperplasia, and in less than 1% of cases, it'll be due to parathyroid carcinoma. Secondary hyperparathyroidism is usually in patients with renal failure. So they'll have chronic hypocalcemia, and in response, they will secrete excess PTH. So it's not an issue with the glands themselves, it's in response to their chronic hypocalcemic state. And then another note on that is tertiary hyperparathyroidism is seen in patients who get a renal transplantation, but they've had this chronic hyper PTH secretion, so that will continue even after their renal transplant, and they should have kind of normalization of that physiology, but they don't. Their parathyroids continue to secrete PTH. One of the ways that this will be tested is you'll get a patient who's in hypercalcemic crisis. So the symptoms of that are nausea, vomiting, abdominal pain, constipation, bone pain, weakness, and neurologic changes. The management of this initially is IV fluids, and then once the patient is no longer in distress, you can start giving them diuretics to take the excess fluid off. But one of the important things to note is you should not give these patients lactated ringers because that contains calcium. So the patient is already hypercalcemic. You don't want to make it worse. You should give them something like normal saline. When you're evaluating hyperparathyroidism, you want to get a PTH level. You'll get their serum calcium and phosphate. You'll do a 24-hour urine calcium, get a vitamin D level, and then albumin and alk phos. And for imaging, you'll get an ultrasound and a sestamibi scan. This is kind of a graph version of the workup. So the patient will come in with hypercalcemia. You'll look at their urine calcium. If that's low, then they have familial hypocalciuric hypercalcemia, which is just physiologically kind of a resetting of the calcium sensing receptor. So they'll have elevated calcium, serum calcium, but they won't have hypercalciuria. So if that's elevated, you'll then want to test the intact PTH. If that's elevated, they have primary hyperparathyroidism. And you can just kind of see how the graph continues on down here. What I do want to highlight is this PTH related peptide. So hypercalcemia in outpatients is most commonly due to this. Hypercalcemia in inpatients is most likely going to be due to malignancy. And that's because of this PTH related peptide. Treatment for patients with symptomatic hyperparathyroidism. You do a parathyroidectomy in these patients. Where it gets a little more tricky is in asymptomatic patients. So these are some of the criteria that are agreed upon and in guidelines to do a parathyroidectomy for asymptomatic patients. You just incidentally discover that they have hypercalcemia and hyperparathyroidism. So it's calcium that's greater than 1 milligram per deciliter above the normal limits, a bone density that's less than 2.5 standard deviations below peak bone mass on a DEXA scan, if they've had a previous asymptomatic vertebral fracture, if they have nephrolithiasis on imaging, if their creatinine clearance is low, or if they have hypercalciuria. You also want to do this in patients that are less than 50 years. The idea being that even if they're asymptomatic, the results of hypercalcemia over time will continue to cause damage. So you want to go ahead and do the parathyroidectomy. Patients with single gland disease can undergo a focused parathyroidectomy. Multi-gland disease will require bilateral exploration. And then from there, you can either do a 3.5 gland, a subtotal parathyroidectomy, or you can do 4 glands with reimplantation. Does anybody know where you would reimplant the parathyroid gland? Yep, the sternocleidomastoid. Is there another place? Yes, the brachioradialis. Great job, you guys. And then very briefly, parathyroid carcinoma accounts for less than 1% of all cases of primary hyperparathyroidism. And this you want to be suspicious of if they have a significantly elevated calcium, so over 14 or 15, or if the pre-op PTH is very high. Some of these patients will have a neck mass, so a large kind of parathyroid mass can also clue you into this, but a lot of these patients will not have any external signs. It'll just be these lab values. So in this case, you want to, again, get your ultrasound of the neck and your sestamibi scan. One, because you'll probably have to do an ipsilateral thyroidectomy for parathyroid carcinoma, and this will allow you to evaluate for any concomitant thyroid pathologies. And in these patients, you only need to do a lymph node dissection if you suspect it preoperatively. Okay, so now we'll do some questions. Who would like to do this first one?
Conceivable was referred to for 10 years after initially successful parathyroidectomy. She now has biochemically confirmed recurrent primary hyperparathyroidism. She has developed nephrolithiasis. What is the next best step in preoperative evaluation for this patient? She had parathyroidectomy. So, because it's not functioning.
B is a good answer, but it's not the best answer. You would want to, so you would want to do both. E is kind of a combination of A and B. So you want to review their prior operative note. Maybe they weren't able to locate all of the parathyroid glands. And then you want to obtain additional imaging because they could also have an additional parathyroid gland, which is rare but not unheard of. Okay, next question.
24-year-old woman workout major calcium level 22 pH level is normal. Correct. Yeah. What is the spur rate next 7 minutes? D.
Yes, D is the correct answer. So they give you an elevated calcium level with a normal PTH level, which means your workup is not yet complete. You would want to get that 24-hour urine calcium and also the calcium creatinine clearance ratio, not ration.
The female presents with methylgenetic almond dehydration and confusion. Serum calcium is very elevated. Functional molecular type for fluid.
IV fluids. Yes. Which IV fluid are we not going to use? LR, correct. Okay. Beth would like the interns to read a question. Thatcher.
20-year woman that's primary hyperthyroid. Reveals a thyroid nodule after the pushes for medullary cancer. What's next?
Here's a hint. You should think back to Gabs's lecture. Yes, good job. What are you looking for with B? Yes. So in this patient who has primary hyperparathyroidism and suspicious nodule, you want to rule out one of the MEN syndromes. So you would want to make sure that they don't have a FIO before you take them to the OR. Okay. And this is our last question.
For serum calcium 14.8 stage 4 intraoperatively firm grayish parathyroid gland with its thyroid lobes encountered several large and grossly positive lymph nodes that are also found in the neck. So concerning for parathyroid carcinoma with like clinically positive lymph nodes. So you want to use ISA's MLOC section with regional lymphadenectomy. Parathyroidectomy with ipsilateral thyroidectomy, subtotal parathyroidectomy, total thyroidectomy, the bilateral lymphadenectomy, fatal tertiary center virgin, parathyroid with the lobectomy and regional lymphadenectomy.
Yep, exactly. So this is a patient who preoperatively you have a suspicion that they might have a parathyroid carcinoma, and intraoperatively your findings kind of confirm that, and you have clinical lymph node disease. So that's exactly right. You would take the parathyroid and block with the ipsilateral thyroid lobe and then do your regional lymphadenectomy. Okay. And that is it. Yay. How do I stop the recording?